Hi, welcome back. Once again, my name is Stephen Taylor, and welcome to part 2 of my presentation, Telemedicine, Flattening the World of Healthcare. In this lesson, we will discuss how telemedicine is being used in intensive care units, or ICUs. ICUs have become a key element in hospital care. ICUs treat the most fragile and complex patients. Between 2000 and 2020, the U.S. population aged 65 and over is projected to grow by 50%. The number of intensivists is predicted to remain stable. To meet this demand, ICU capacity must be expanded. One possible solution to this crisis is tele-ICU. Tele-ICUs, or eICUs, are networks of audio-visual communication and computer systems that link critical care doctors, also called EMDs, and nurses, also called ERNs, to intensive care units at remote hospitals. These EMDs, or tele-ICU doctors, work from a command center and communicate by voice with the ICU personnel at a remote location. The EMDs within the command center can receive pictures and clinical data about the patients. Tele-ICUs enable a small number of EMDs to oversee the care of a large number of patients. A tele-ICU system includes hardware that amasses patient data and transmits it, including video and voice, from the ICU to the command center. The data includes information about the patient's physiological status and may include vitals such as EKG and blood oxygenation or other electronic medical data. Typically, the hardware provides the clinician in the command center and the ICU with the same patient data. Tele-ICU software includes programs to control the monitoring and information transmission hardware function. Tele-ICU software is designed to interface with and electronically accept data from other ICU systems such as laboratory results, medications, nurse flow sheets, and physician notes. In 2006, Moses Cone Health System implemented a Philips VisiQ tele-ICU system. The Moses Cone tele-ICU command center covers 106 beds in 4 hospitals. I had the privilege of interviewing Phyllis Griffin, the E-Link Critical Care Director for Moses Cone Health Systems. Before the tele-ICU, acute patients from Wesley Long, Annie Penn, and Women's Hospital Center were transferred to Moses Cone Hospital. Now they receive the same level of care in either hospital. ICU nurses are now more confident and have greater job satisfaction. The after-hours ICU nurses can summon an intensivist with the touch of a button, while before they had to disturb the on-call attending physician at home when there was a question or a problem. The greatest benefit yielded from the tele-ICU is a significant decrease in the average patient length of stay and the mortality rate. The tele-ICU is now the standard level of care at Moses Cone, but at the onset, some doctors and nurses were skeptical. Nurses were concerned that they would constantly be monitored. Most Big Brother fears were alleviated when they learned that the system sounds a tone that alerts them when the control center is monitoring, and the system does not videotape. Some physicians were hesitant to give up control of their patients. To deal with these fears, physicians were given options of voluntary participation. Almost all physicians are now full participants. The U.S. population aged 65 and over is projected to grow dramatically, which will create a shortage of intensivists. Tele-ICUs can help solve this dilemma by enabling a small number of EMDs to oversee the care of a large number of patients. The Moses Cone Tele-ICU is a great example of how a Tele-ICU can help improve the standard of patient care. The Moses Cone Tele-ICU has produced results which include better accessibility of care, improved job satisfaction for ICU staff, decreased length of stay, and improved patient outcomes. This concludes my presentation, and I hope you've learned a few things about telemedicine and tele-ICU. Thank you for watching.